can be benign. Okay.
Okay. You said it can be benign. Yes.
It can be malignant.
It can be malignant.
Simple.
So under what? Simple is a classification.
Sir?
Where are we? Do you mean simple is a classification on its own?
No, it's under benign.
Okay, you mean under benign is simple.
Yes.
So it's not on its own. Okay, your time is up since so Dr. Amina classified goiters as benign and malignant, and under benign she mentioned that they is simple. So as I told you earlier on, the essence of an impromptu interaction with residents, one is to assess your own self. Okay, you have to assess yourself on your personal readings. And two, another reason is for motivation. Okay, you when you are asked a certain question, because sometimes there are some things you will be asked, you will assume you know them. It is after you are being asked you realize that it's not very clear to you. Okay, then you will be motivated to go and read. And another aim of this impromptu interaction is to guide you on how to speak up. Okay, clinical exams is all about talking business. You must learn how to speak up. If you don't speak up, you get low marks. And lastly, and most importantly, is guidance. When you are asked a question, you will be corrected. And when you are corrected, then you will now see how to answer the question correctly, so that subsequently when you are asked, you will not have any challenge answering that question. So now I'm going to answer this question, even though we've discussed it before. Then you will now compare it with your own answer you give, and if you were to be marked, you will now see how you will score that. Goiters generally are classified into simple goiters, toxic goiters, neoplastic goiters, and inflammatory goiters. Okay. Now we said simple goiter. We define simple goiters are goiters that are not hyperthyroid or hypothyroid, neither are they malignant, meaning they don't have symptoms of hyperthyroidism, symptoms of hypothyroidism, and they are not malignant. Those are simple goiters. And simple goiters could either be diffuse, okay, or they could be nodular. And they are also broadly classified as endemic goiters and sporadic goiters. Now, toxic goiters, as we mentioned, they could be diffused, okay, they could be nodular, which could either be solitary nodules or multinodular goiters. toxic multinodular goiters. Now, neoplastic goiters are either benign or malignant. Now, there are various adenomas that are benign, but the one of interest we mentioned in the classification were papillary thyroid cancer, follicular thyroid cancer, medullary thyroid cancer, and anaplastic cancers. Then inflammatory goiters mentioned autoimmune thyroiditis, like the Hashimoto's thyroiditis. We mentioned acute suppurative. We mentioned subacute suppurative thyroiditis, like diffusion thyroiditis. We mentioned Riedl's thyroiditis and specific infective thyroiditis. So this, if you are asked to classify goiters, that is how you approach it. There are four main categories: simple goiters, toxic goiters, neoplastic goiters, and inflammatory goiters. So you see, in your own answer, you concentrate mainly on the neoplastic goiters. So you have left out simple, toxic, and inflammatory goiters. So you see, if you approach it this way, you will miss a lot of marks and you hardly pass that question, whether in oral or written. Okay, so we'll move to the next question. So who is the volunteer? Dr. Abakar.
Yes, sir.
Okay, you are up. The next question is for you.
Okay, sir.
You are ready?
Yes, I'm ready.
Okay. Questions 2 says, define the following terms: endemic goiters, simple goiters, solitary thyroid nodule, and dominant nodule. So you will take each and define. So you have 5 minutes. You can go ahead.
Okay, sir.
Yes. Go ahead.
Let me take 30 seconds to arrange the stuff.
Well, it's an impromptu discussion, so you can start with the.
Okay, sir. Yes, sir. The endemic goiters. Endemic goiters can be defined as when a goiter is found in about 10% of a population, is said to be an endemic goiter. So in 10 or more than in a community, or is endemic in about 10% of the population, is known as an endemic goiter.
Okay.
And yes, sir. A simple goiter is any goiter that is not related to increase in thyroid hormone. Hence, there is goiter, but there is no biochemical evidence of any increase or decrease in thyroid hormone or evidence of thyroid hormone activities. And in solitary thyroid nodule is a discrete palpable nodule in an otherwise normal thyroid gland. And a dominant thyroid is that this I will explain it. I don't know any definition for it, but it shows that when there are multinodular thyroid gland, and one of the thyroid gland has highest activity and is shown a highest level of activity among others, is said to be a dominant nodule. Thank you.
Okay. That is a very fair attempt. Okay, and when you answer questions and attempt all, the chance of you passing that question is high. Leaving a question blank, the chance of getting 0 there is high, because in a closed marking system, they will hardly give you 0, but of course, they will give you below the pass mark, which is veto failure. So when you are asked to attempt, okay, it might not necessarily be an exact definition of what it is, but the aim of all this is, after attempting and you did not get it right, okay, so when you are corrected and you go over it, you will hardly fail such question when you encounter that again. Okay, so that is a fair attempt. Okay, so
Thank you.
you are welcome. So when we say an endemic goiter, okay, goiter that involve 10% of the population in a community, that is an endemic goiter. Goiter that involve up to 10% of the population in a community, it is an endemic goiter. And the reason why you will have an endemic goiter in a community is because there is a risk factor in that community that makes the population in that community predisposed to goiter. And the common risk factor that cause endemic goiter is iodine deficiency. Okay, iodine deficiency. Now, a simple goiter is defined as a goiter that is not hyperthyroid or hypothyroid, neither is it malignant. So what it simply means is that, okay, this goiter is not associated with increased activity. Okay, that is hyperthyroidism. There is no excessive hormonal activity. Okay, so goiter that is not associated with increase or decrease hormonal activity, neither is it malignant, is defined as simple goiter. Okay, so you have to include these 3 parameters. Okay, it's not associated with increased hormonal activity, decrease hormonal activity, neither is it malignant. So that is simple goiter. So if you are asked to define it, these 3 keywords must be there. No increased hormonal activity, no reduced hormonal activity, neither is it malignant. Okay. Now the third question here is solitary thyroid nodule. Both this third and this fourth questions are discrete nodules. When you palpate a discrete nodule on the thyroid gland, that discrete nodule could either be a solitary thyroid nodule or a dominant nodule. When you say a solitary thyroid nodule, okay, is a discrete nodule that is felt in an otherwise normal gland. Other part of the gland appears or is felt normal. You won't palpate any other swelling, but you will feel a discrete okay, nodule. So that is solitary thyroid nodule. Okay, it's a nodule that is a discrete nodule that is felt in an otherwise normal gland. Okay, you have the gland, the thyroid gland, and it is impalpable, but you now felt a discrete nodule somewhere. So that is a solitary thyroid nodule. Okay, then when you talk about a dominant nodule, it means it's a palpable, is a discrete nodule that is felt in a diseased gland. The gland, other part of the gland is already diseased. You can feel an enlarged thyroid gland, but you now felt a prominent nodule in a diseased gland. That is a dominant nodule. In that diseased gland, that palpable swelling is the dominant nodule. I hope that is clear.
Yes, sir. Yes, sir. So, sir, if I get this right, that means the differences is that one is also a discrete nodule in normal gland. That is a normal gland. That is the normal gland is what differentiates the dominant gland and the solitary gland, solitary thyroid nodule.
The main difference is in solitary nodule, other part of the gland is normal. It is only the solitary nodule that is the problem, that is the diseased part.
Yes, sir.
While in the dominant gland, the other part of the gland is diseased, but there's one prominent one that is easily palpable, that is discrete, prominent, and felt easily. I hope that is clear.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
We have Dr. Kashim. Are we together, Dr. Kashim? Dr. Ali?
Sir, we're together.
We are together. So it's your own turn now. Outline 5 investigations for a toxic multinodular goiter. You can go ahead. You have 5 minutes.
All right, sir. So the first investigations I would like to do for a toxic multinodular goiter is the thyroid function test. So I'll be looking out for elevated T3 and then depressed TSH, or elevated T3 only. And the second one, I would like to do a fine needle aspiration cytology to confirm whether it's a neoplasm, though it can't differentiate between a benign or a malignant one. Then the third one, I would like to do a thyroid scan, a soft tissue scan of the neck that will tell me that that tissue is actually coming from thyroid, and then the regional lymph nodes and other abnormalities there in the region of the thyroid gland. Then I would also like to do an indirect laryngoscopy for medical legal reasons to check the status of the vocal cords.
Okay. You can go ahead.
Yes, sir. Then I can do other investigations, prepare the patients for surgery, maybe full blood count, then it's a full blood count ECG, then a chest X-ray too can give me the size of the heart, maybe from hypertension, cardiomegaly, and then the size of the heart generally, sir, and maybe also retrosternal extension. Then there's an X-ray of the neck too. X-ray of the neck, AP lateral can show me, AP will show me deviation of trachea, lateral will show me compression of the trachea by tumor or the swelling.
Okay. Your question says 5
5. So you didn't stop me, so I continued because I felt I mentioned some irrelevant ones or some that should be after, should come later, sir.
So which one is irrelevant among the ones you mentioned? So that
There's none that is irrelevant. Though in order of first, maybe to confirm my diagnosis first, then to look for extent of the disease, then to prepare the patients for surgery in that order.
Okay. So which 5
Yes.
you choose it now? Just mention them.
Thyroid function test, fine needle aspiration cytology,
Okay.
thyroid scan,
Okay.
then X-ray of the neck, epilateral,
Okay.
then indirect laryngoscopy. I think
Okay.
I'll go with these 5.
Okay, you've chosen 5. Now, before we
Yes,
go
sir.
ahead, you did well. That is a very good attempt. But what do you mean by
Yes.
thyroid scan?
Sir?
What do you mean by thyroid scan?
No, it was a slip of tongue. I said I corrected to soft tissue scan of the neck.
Which one? What do you mean by soft tissue scan of the neck? What
Okay,
is
ultrasound scan of the neck, or thyroid ultrasound scan.
okay, you mean high resolution ultrasound scan?
Thyroid.
Because when you mentioned
Yes, sir. Yes, sir.
scan, it entirely meant something else. It's
Yes, sir. 1 to 3. That's yes, sir.
It's radioiodine scan, radioactive scan, either with iodine, radioactive iodine, or technetium 99. So that is what we
Yes, sir.
refer to as thyroid scan. But you have to mention it. Is it high resolution ultrasound scan you meant, or
Oh, okay, sir.
or even MRI? So you have to be clear. Okay, that is a
Okay, sir. Ultrasound scan.
outline 5 investigative modalities, okay? For a toxic multinodular goiter, of course, you mentioned thyroid function tests, which is okay when you mention all what you are looking for. That is good. Then the fine needle aspiration, you said it has limitation. It cannot differentiate benign from malignant. That statement is not true. Then what is the essence of doing the FNAC?
Yeah.
So to show me is a neoplasm, but it can't say if it's benign or malignant in the case of follicular cancer or papillary.
Okay, the aim of your fine needle aspiration cytology is exact opposite of what you just said, is to differentiate benign from malignant goiters. Okay, it will tell you if the goiter is benign or malignant. However, there is a limitation in differentiating follicular neoplasms.
Okay, sir.
Do you understand?
Yes, sir. Yes, sir.
There is limitation in differentiating follicular neoplasm, meaning it cannot differentiate follicular adenomas from follicular carcinomas. But however, when you are differentiating malignant cells, it will show you features of malignancy. Loss of polarity, hyperchromasia, increased nuclear cytoplasmic ratio, mitotic figures, and all those stuffs. It shows you features of malignancy. However, if you are dealing with a follicular neoplasm, it cannot differentiate follicular adenomas from follicular carcinomas because only vascular or capsular invasion that can differentiate this type of neoplasm, which cytology cannot do that. Okay, except you take.
Yes, sir.
Is it clear now?
Yes, sir. Yes, sir.
Yes, sir.
So Well, fair attempts. All other details are in the previous lecture, but of course you did. So, the fourth question discuss the medical management of a toxic goiter. Let's go back to Dr. Amina. Dr. Amina, you want to attempt?
So I can't even attempt. I didn't join that lecture. I think I'll defer to somebody else to attempt.
You did not join the previous lecture.
No, sir. I didn't join.
So who wants to attempt this question? Who wants to attempt this?
So let me attempt the questions.
Okay, you can go ahead.
Okay. The management of a toxic goiter. Now, it will start with the history. History, which consists of the symptoms of compression due to the large gland or not. Then the symptoms of toxicity. Then also the symptoms of nervous symptoms. Now, the symptoms will consist of nervosity, emotional liability, anxiousness, and others. Then the symptoms of compression, sir?
Look at the question again. It says medical management of toxic goiter.
Okay, thank you, sir. Now, let me attempt again.
Okay.
Yeah. Now, being taking your history examination, now the management will comprise of it's a toxic goiter. It's already a toxic goiter. So you give medications. That medical treatment of toxic goiter would include the giving of carbimazole, tabs carbimazole, about 15 to 30 milligrams. That is TDS, that is 3 times daily. Then you can also add up with, because they usually present with, this will help to lower the thyroid hormones in the body. Now, they also have, because of the toxicity, they also have they also have tachycardia. So you add up with propranolol, part of the management. Now, the propranolol is given in 80 milligrams, also BD or TDS, depending on the level of the pulse rate the patient is having. This will help in lowering the toxicity of the patient. So the other thing is you also advise the patient on okay, after giving that medication, then it's expected that you check the patient after 3 to 4 weeks. Sorry, 3 to 4 weeks, yes. So some advocate 4 to 6 weeks also for the level of toxicity. And then you check, if every follow-up the patient is coming up, you check his pulse rate and then the symptoms, the subsiding, the level of the symptoms he was initially admitted, he was initially seen for. Then after that, then you decide on whether to take, when the symptoms have subsided, then you prompt him for possible surgery, which would help in whether subtotal thyroidectomy or even total or near total thyroidectomy patient. Then also you also follow the patient up. However, before taking the surgery, you also give the patient glucose iodine, which is not also advocated recently due to the efficacy of the iodine is not really advised. So am I on the?
Okay. Well,
am I on the right track? So,
okay.
So do I have to go to the surgery, the follow up, and everything,
Okay.
or just no? It's not easy to have an impromptu question, sir.
Yes, that is the entire aim of the discussion. Now,
Yes.
there is a fair attempt, but the essence actually is to guide you. So that, as I told you, when going for an exams, you go to an exams with preformed answers, with preformed information. If you are asked a question, maybe you have never had before, you've never attempted before, there is slim chance of you answering in an organized manner. Okay, so when you are asked on medical management, this is a specific question, medical management of toxic goiter. You see, when they say medical management, it means the use of drugs, okay, in the treatment of toxic goiters. So you can start by saying medical management entails the use of drugs in the treatment of toxic goiters. And the aim of medical management is to render a patient euthyroid. That is the aim of medical management, is to render a patient euthyroid. Okay? And when you say euthyroid, they don't have symptoms of toxicity. Is that not so? Are we together?
Yes, sir.
Then the next thing you mentioned, the indications for medical management. The indications for medical management. When you are treating toxic goiters, children, okay, it's an indication, okay? When you are treating toxic goiters in females, you use drugs. When you are treating toxic goiter in a non-palpable gland, okay, non-palpable gland is an indication, okay? When you are treating a recurrent toxicosis after following subtotal thyroidectomy, it's an indication, okay? So hope is clear, all the various indications for the use of drugs.
Yeah, very clear.
Yes.
Yes, sir. Very clear.
The next thing you now mention that this drug treatment, medical management, is usually done in 12 to 18 months. However, the pitfall is about up to 50% of these patients tend to have recurrence in 6 months. So you can see it's a serious problem if you are to use only medical management for a toxic goiter. So how is it done? Now, the medical management is with the use of antithyroid drugs, one, antithyroid drugs, and two, beta blockers. Medical management uses antithyroid drugs and beta blockers. Now, the antithyroid drugs we discussed in the previous lecture, we said the carbimazole that is commonly used. There's the carbimazole, the metimazole, the propyl tyrosine, and the Lugol's iodine. Remind me, I'll correct you on what you said about Lugol's iodine after the discussion. Okay, so the antithyroid drugs could either be carbimazole, metimazole, propyl tyrosine, Lugol's iodine. All these are antithyroid drugs. And the beta blockers include the propranolol, the nadolol, esmolol, various beta blockers used. So let's talk about the carbimazole. You now talk about the carbimazole, okay? said carbimazole is given as loading dose and maintenance dose. The loading dose is given as 15 to 20 milligrams 8 hourly. And of course, in the first 2 weeks, patients will be relieved of symptoms clinically. Okay, after about 4 weeks, patient will become euthyroid. When you repeat the thyroid function test, then you now place patients on maintenance dose, which is 5 to 10 milligrams 8 hourly. Is it clear? 5 to 10 milligrams 8 hourly. And since we are talking about only medical management, this is continued for about 18 months, okay? Then it is stopped. Now, however, when you are considering other options of treatment, after patient become euthyroid, you now offer either surgery or radioactive iodine therapy. Okay, so for the medical management, we mentioned the drugs. You also talk about the side effects of carbimazole. Okay, and in our last lecture, which you should go and review, we mentioned the mechanisms of action of carbimazole, the side effect of carbimazole, how you follow up patients on carbimazole. Then you now talk about the beta blockers, pranolol. We said it is given 40 milligrams of iron. Okay, and the aim is to abate the sympathetic adrenergic symptoms. So that is the medical management. Okay, we talk about, so please, it should be clear when you are answering questions. You should be organized, and for you to be organized, you must understand what is being asked. Okay, you have to understand the question, that what we are dealing with here is medical management alone. So you have to see what that medical management is. What is the aim of your medical management? Who are the categories of patients you offer medical management for? Okay. Then how is it even done? Okay. What drugs do you use? How do these drugs act? What are the side effects of these drugs? How do you follow up patients on these drugs? So the aim of this, we've already discussed all these things, is just guidance on how to answer questions. Is it clear?
Yes, sir. Yes, sir. I think it's the most important thing, sir.
Yes.
The guidance is the most important. Stuff might be there, but without direction, we are straight.
You have the box, but if you don't know how to put them together, you have difficulty answering. So the last,
yes, thank you.
Who is attempting the last question, or should we stop here? Or do we have a volunteer for the last question?
I think we are 4 of us, sir.
So who is volunteering for the last question?
Can I attempt?
Yes, you can go ahead.
Okay, so after thyroidectomy, they can have early complications or late complications. For example, the early complications, they might have hypothyroidism as a complication. They can have recurrent laryngeal nerve palsy. They can go into crisis, thyrotoxic crisis. They can have wound infection.
Okay.
They can develop hematoma also, which can lead to respiratory obstruction.
Okay.
And then late complication, that's where they can have hypothyroidism. They can have it can recur. That's all.
Okay. Fair attempt. So we said the way you started is actually okay when you are asked to describe complications of surgery. You classify them into an early and a late complication. Okay. You can classify them into the early complications and the late complication. Now, the early complications include airway obstruction. This airway obstructions is caused by tension hematoma, laryngeal edema from difficult intubation, tracheomalacia after removing a giant goiter or long-standing goiter, bilateral injury to recurrent laryngeal nerve. All these are causes of airway obstruction. And this category is important because it's very dangerous. You can see that's why it's clearly stated as a complication on its own, airway obstruction. And these are various causes of airway obstruction. Now, your patient may present with hypoparathyroidism. And hypoparathyroidism will present with hypocalcemia. And patients will manifest the features of hypocalcemia like circumoral numbness, twitching, spasm, carpopedal spasm, okay? And this usually occur in 3 to 5 days after surgery. And you correct that using calcium gluconate, 10%, 10 mils over 10 minutes. Then you place patient on maintenance calcium. Okay. Then patients might have recurrent laryngeal nerve injury. This is unilateral now, and they will present with hoarseness of the voice. They can also have injury to the external branch of the superior laryngeal nerve. And they will have inability to achieve a high-pitched voice. When the internal branch is injured, they will have loss of sensation in the pharynx and they can present with choking. Now, they can also have crisis, thyroid crisis. Thyrotoxic crisis results when a patient is not made euthyroid before operation. Okay, they present with exaggerated symptoms of hyperthyroidism. They can present with wound infection. All these are early complications of thyroidectomy. The late complications will include thyroidism that occur in 2 to 5 years. We mentioned this in detail in our last lecture. Then they can have recurrence. Okay. As a complication, they can have keloids in those patients that are predisposed to. So there is a very interesting way of interaction where you see you answer questions impromptu. Okay, now I already told you when you are faced with this, our entire aim is just to assess yourself, your preparedness for an exams, and a motivation for you. You need to be motivated so that you go and read, and also guidance on how to answer questions in your exams. And it's very important you learn how to speak up to an examiner. So all these are the purpose of an impromptu interaction. So do we have any questions? Any questions, please? Any question? So since there are no questions, I think we are going to end the meeting here. So thank you all for participating.